We're talking on adrenaline versus tranexamic acid for intraoperative hemostasis in PDR, a randomized control trial. So no financial interest in this presentation. So, or the products used. So intraoperative bleeding in diabetic vitrectomy is one of the major concerns, especially for a surgeon who's sitting and operating 1, 2, 3 hours. So it obscures the visualization and also prolongs the surgical time. So what are the techniques for bleed management which has been used previously? Pre-op anti-VEGF has been used. Intraoperatively, you raise the intraocular pressure. You can do multiple, intraop diathermies. Also, you can use heavy liquids like PFCl to tamponade or, reduce the bleed which happens. So let's talk about some pharmacological adjuvants which have come recently into the limelight. So one of them is tranexamic acid, and the other one is adrenaline, which was also used previously. So what is the mechanism of tranexamic acid? It's an antifibrinolytic. It basically stabilizes the clot and prevents the action of plasminogen conversion to plasmin and then formation of fibrin. And whereas the adrenaline, through its alpha-1 receptor, it acts on the alpha-1 receptor and causes vasoconstriction, and thereby reducing the flow and thereby reducing the intraocular bleed. So the aim in this study was to directly compare both these pharmacological adjuvants added to the infusion bottle in achieving intraoperative hemostasis, that is tranexamic acid versus adrenaline. And so this was the methodology of a prospective randomized control trial, 40 eyes of 40 patients, 20 in each group, 1:1 randomization. And eligible patients with PDR were taken, and data analysis was done with SSPS. So these were the inclusion-exclusion criteria. Adults more than 18 with diabetes, active PDR, non-clearing vitreous hemorrhage, waiting after 1 month non-clearing. Even a few fractional detachments were taken. Exclusion were recent anti-VEGF. So anti-VEGF was excluded from this study. That means now the trend is give anti-VEGF 5 days or 1 week pre-op and then take the case. So anti-VEGF was excluded, not given. Previous VR surgery excluded, one-night status excluded, any cardiac CKD, and those on anticoagulant were also excluded from this study. So it was randomized 1:1. So we prepared tranexamic acid 100 milligram per ml, so at least 4 vials. So 1 gram, 500 milligram in 5 ml, so at least 4 vials of those. So 1 gram was used in 500 ml of BSS, and adrenaline was only 1 milligram per ml. It mixed in 500 ml of BSS. So this masking was also done. The surgeon also did not know what was used, and also there was a primary evaluator who was observing each case, so they were also masked towards this. So what were the outcome measures? So intraoperative bleeding score was there, 0 to 3, no intraoperative bleeding 0, 3 severe bleeding requiring prolonged maneuvers, and also visibility score 1 to 3, poor visibility and also good visibility. So primary outcomes were the intraoperative scores and the number of diathermy applications. Secondary outcomes were the visual acuity and the intraoperative visibility score, mean operative time, etc. So these were the baseline demographic data. Both groups were age matched. The sex, male, female was also age matched. Equal number of hypertensives, and those with the previous PRP was also matched, and preoperative BCVA is also similar in both the groups. So these were the outcome measures. So bleeding score. So adrenaline group had less amount of bleeding as compared to tranexamic acid, 1.3 plus minus 0.5 as compared to 2. According to the bleeding score, what I showed previously, this was quite significant, and even the endothermy applications were lesser in the adrenaline group as compared to the tranexamic acid group. Whereas the operative time and the visibility score were almost similar in both the groups. The second outcome measure, early post-operative vitreous hemorrhage, 1 was there in the adrenaline group and 2 were in the tranexamic acid group. Again, it was not significant. The sample was too small to provide a significance, and also visual acuity at 1 month was similar in both the groups, and no other intraop complications or post-op complications were seen. Even systemic complications were not seen. So there are few limitations of this study. Small sample size. It's a single center study. There was no control group. We should also have had a control group of normals. We did not have that. And if you look at the literature review, this is the first study to analyze the intraoperative use of these two adjuvants, against each other. So no literature is there on intraoperative use for this particular vitreous hemorrhage in PDR patients. Most of them, the literature examines only the post-vitreous cavity hemorrhages after use of these adjuvants. So to conclude, adrenaline, when compared to tranexamic acid, has a superior hemostasis, reduced bleeding scores, and fewer number of diathermy applications as compared to tranexamic acid. Yeah, thank you. So this is the case where you can see adrenaline has been used, and when you're removing these FPs, even those point bleeders are blanched because of the use of adrenaline.
Thank you, Shishir. How many times did you have to raise the IOP in these two groups? Is there any comparison? And
Yeah,
how much time you had to keep it raised?
Yeah, IOP was raise lesser in the adrenaline group as compared to the tranexamic, because
but
the
it doesn't come
tranexamic
in your-
acid still oozes.
Yeah, but it doesn't come in your comparison.
Yeah, that I didn't.
Actually, this was used year as early as 1987. But in 2021 in Euretna, there is a paper, similar paper.
Yes, abstract is there.
Yeah, abstract is there, and in fact, they have used intraoperatively.
Yes.
And second thing is, in that case, they have given preoperative ILIA in all cases in both the groups.
Yes.
So, have you given anything, number one?
No, no anti-VEGF. Then we don't know what is working.
Okay. So, number two, actually, when they are giving systemically, they have come across CRVO and all, because it tends to clot.
Clot, yes.
So, when we are, exposing the vitreous cavity for such a long time, is there any risk of going in for CRAO or CRVO in these cases?
So there's
Theoretically.
one case report of CRO formation has been reported with the use of adrenaline. Not intraoperative for diabetic, but for the when you add in the infusion to dilate the pupil in cataract surgery, it has been reported.
Thank you.